There are 4 general categories of changes to the Advanced Cardiovascular Life Support Guidelines. Changes to the cardiac arrest algorithm, the addition of a new immediate post-cardiac arrest care algorithm, and updated recommendations for airway management and synchronized cardioversion. Let's start by reviewing changes to the cardiac arrest algorithm. The 2010 guidelines simplify the algorithm and create a circular chart to emphasize the interventions that have the greatest impact on outcome. The priority is the 2-minute continuous period of high-quality CPR and defibrillation. All advanced interventions, including IV access, drug delivery, and advanced airways, should not interrupt chest compressions and shocks. Rather, they should be performed or administered strategically after the brief pause for defibrillation. These actions continue until ROSC, when healthcare providers will initiate post-cardiac arrest care protocols. Within the cardiac arrest algorithm, there are several drug administration recommendations for both cardiac arrest and non-arrest patients. For patients in cardiac arrest, the use of vasopressors and antiarrhythmics continue, consistent with the 2005 guidelines. During cardiac arrest, providers should administer a vasopressor every 3 to 5 minutes. Epinephrine is commonly used, although vasopressin can replace the first or second dose of epinephrine. Regardless of the vasopressor given, one should be delivered every 3 to 5 minutes. ACLS providers should administer amiodarone for refractory VF and VT. However, the American Heart Association no longer recommends atropine for routine use in managing pulseless electrical activity, or PEA, or asystole. The available evidence indicates that atropine is unlikely to have a therapeutic benefit. If the origin of the regular, monomorphic wide complex tachycardia is unknown, ACLS providers may use adenosine in the initial treatment and diagnosis. However, for irregular wide complex tachycardias, adenosine should not be used because it may cause degeneration of the rhythm to VF. For symptomatic bradycardia, atropine is the first-line treatment for all symptomatic bradycardias, regardless of type. The American Heart Association now recommends intravenous infusion of chronotropic agents as an equally effective alternative to external transcutaneous pacing when atropine is ineffective. Although defibrillation recommendations did not change, there are new recommendations for synchronized cardioversion. For unstable atrial fibrillation, the guidelines recommend that the initial biphasic energy dose be between 120 and 200 joules. For unstable SVT or unstable atrial flutter, the guidelines recommend that the initial biphasic energy dose is between 50 to 100 joules. Cardioversion with monophasic waveforms should begin at 200 joules and increase in stepwise fashion if not successful. The guidelines also recommend cardioversion for unstable monomorphic VT with a biphasic or monophasic initial energy dose of 100 joules. If there is no response to the first shock, it is reasonable to increase the dose in a stepwise fashion. If the initial shock fails, providers should increase the dose in a stepwise fashion. The return of spontaneous circulation, or ROSC, is no longer the end of the cardiac arrest protocol. More and more scientific studies conclude that survival rates improve significantly with a comprehensive system of post-cardiac arrest care. That's why the American Heart Association has developed the immediate post-cardiac arrest care algorithm. This algorithm can guide EMS systems and medical centers in offering a structured and integrated system of care for patients who achieve ROSC. The goals of this new algorithm are to provide guidance for pre-hospital personnel in transporting the out-of-hospital patient to an appropriate facility with post-cardiac arrest care, provide guidance to hospital personnel for transporting the patient to a critical care unit capable of providing post-cardiac arrest care, identify and treat the causes of the arrest and prevent a recurrence, optimize cardiopulmonary function and vital organ perfusion, especially to the brain and heart. Other objectives of immediate post-cardiac arrest care include considering hypothermia to optimize survival and neurologic recovery, identifying and treating acute coronary syndromes, reducing the risk of multi-organ injury, gathering data to assess recovery, and offering rehabilitation services to survivors if needed. Brain injury and cardiovascular instability can indicate whether a patient is able to survive after cardiac arrest. Therapeutic hypothermia is the only intervention that has been shown to improve neurologic recovery. That's why providers should consider hypothermia for any patient who is comatose after ROSC, and particularly for patients with out-of-hospital cardiac arrest with VF as the presenting rhythm. Several studies show good outcomes for patients whose bodies were cooled to 32 to 34 degrees Celsius for 12 to 24 hours. One study followed cardiac arrest patients who were comatose on arrival at the hospital and received hypothermia treatment. In 3 separate studies, 20 to 50% of those patients had good neurologic function 1 year later. Hospital personnel should not delay reperfusion therapy for ST segment elevation myocardial infarction or STEMI patients during post-cardiac arrest care. It is safe to combine percutaneous coronary intervention or PCI and hypothermia after cardiac arrest. Rapid transport to the catheterization lab remains the focus for STEMI patients.
Critical actions for post-cardiac arrest care include optimizing hemodynamics and arterial oxygen saturation, monitoring airway placement and ventilation status with quantitative waveform capnography in intubated patients, acquiring a 12-lead ECG, and inducing therapeutic hypothermia.